is about my philosophy and technique of reconstruction. So mainly, I think we are focused on those chronic instability. We have heard a wonderful presentation about the acute and the subacute status. Maybe we would like to discuss a bit more on the chronic situation. The stability of the scapholinate joint is obviously depending on a lot of soft tissue, not just the interosseous ligament or the volar extrinsic ligament. We know we have just heard about the dorsal intercarpal ligament and also the distal component of the SCT ligament complex. So it is not unreasonable to talk about is not just a scapular ligament, but it's a scapular ligament complex. Actually, it's a kind of idea I brought through almost 20 years ago when we started to talk about this sort of idea. And then the effect of ligament section have been done many, many times. Still, we will appreciate the importance of the scapular interosseous ligament as a major stabilizer, but those secondary constraints, mainly the extrinsic ligament, are certainly, if not more important, may have almost shared equal importance. And we understand that repetitive motion will cause deteriorous effect on the carpal kinematics. So sometimes initial injury may not be seen at the first instant, but then gradually we see the deteriorous effect. And the dorsal tear will probably lead to the scapular diastasis, but palmar tear will lead to more rotational instability. And somehow we will say that we have all see the different conflicting situations. Sometimes we see the interosseous ligament is damaged, and but theoretically the extrinsic ligament is weaker. They should damage before the interosseous ligament. But often in arthroscopy we may just see the tear of the interosseous ligament. It's because they are, although they are stronger, but they are also much shorter than the extrinsic ligament. So somehow when they are subjected to the injury fall, they may actually rupture before the extrinsic ligament. So in the other words, you will see the intrinsic ligament is being ruptured, and then you see the extrinsic ligament does not have any morphological damage. It doesn't mean that the extrinsic ligament is completely normal, because it can be injury from the first instant. It's just because of the force of the injury or the moment of injury may not damage the ligament, but with the deteriorous effect may comes in with a cyclical loading of the wrist. Another difficulty is about the chronicity of the scapular. When we can repair and when we cannot repair. This is always controversial. Many authors, including me, could probably be 0 to 4 weeks acute, but the subacute is a very, very diversity from 4 weeks to 2 to 3 months. But in my opinion, I think, and also perhaps in others' opinions, anything more than 6 weeks will become very difficult to repair. And if you see a case with a chronic CT 6 weeks, one have to also consider some reconstruction method. So, but unfortunately, many scapular ligament injury cannot be diagnosed early on because of the difficulty in the diagnosis, and we all know about that. So that's why sometimes we have a very result with different type of acute repair method compared to the reconstruction method. In my time when I start encounter a problem, I think one technique as advocated by Terry Ripple is the controlled arthrofibrosis, means putting multiple KY across scapular joint to induce arthrofibrosis. That has been shown, according to his study, that if the injury is less than 3 months with a less than 3 millimeters scapular gap, there's a good result of pain relief. But if otherwise, the result of the clinical outcome may not be expected. So the timing and also the severity of the injury may actually dictate the result. I use it quite a lot in my practice, particularly for the acute stage. Like in this case, you can see acute scapular dissociation after fall from height, and I fix it about 10 days with the multiple pinning, thinking that it should be going into a good way, but it's not always predictable, because like in this case, once I remove the KYs, there's the instability recur. So that's all. Lateral healing, particularly in the case of scapular ligament injury, may not be very reliable. We may need some sort of more reliable reconstruction method. So we talk about the reconstruction options. There has been multiple techniques have been developed over the years. We can grossly divide it into anatomic reconstruction, try to reconstruct those ligaments that contribute to the stability of scapular joint, or the non-anatomic reconstructions, such as some of the capsulodesis or tenodesis, try to restrict particular fraction and the pronation deformity of the scaphoid in order to avoid prolonged long-term symptom, or some may even give up because once you have instability, it may not be possible to do soft tissue procedure. Then we go for salvage procedure like the limited carpal fusions and other type of symptomatic relief. So it's very hard to decide what to do in which patient. At one time, particularly in my time when I started to develop the method, the bone ligament bone reconstruction has been popular, at least has been considered to be a wise thought. But that has not been always the easy, because bone ligament bone reconstruction biomechanically is a rather weak construct. It's very difficult to have a good bone fixation. This is one of the cases that have been done before trying to use this bone retinacular bones construct. It's found to be very difficult to fix the bone and also quite risky to create a trough. It's only provide uniplanar reconstruction, and you can easily infringe vascularity and end up into some complication like avascular necrosis. The healing potential of this small bone is also questionable. Of course, we are familiar with this ligament reconstruction. Against in the past a few decades have been since the 1990s, have been a couple of the different view continues to go along even to the current way, but no one has been demonstrated which is the best, because some of the problem is also the complexity of the reconstruction. Like this case, I've tried the Lynchine reconstruction, but it's very difficult, and also it end up into some sort of complication. So most of the method, particularly in the past, we focus on dorsal reconstruction, thinking because the dorsal ligament is the strongest. But it may not be really true, because very often this dorsal reconstruction does not correct the diastasis, and may result in recurrent diastasis. And more importantly, is actually most of this version actually limited motion and the grip strength. And as stylistic as comment, many of these reconstruction are complex but not completely reliable, and we may probably need a simpler method. What inspired me about the rolling reconstruction is about Dick Berger, who is actually my mentor when I visited him in the Mayo Clinic in 1996. And he's actually emphasized that maybe the palmar region needs to be attended if we want to justify a rotation stabilizing agent to just a simple dorsal repair. So Dick continues to inspire me, and as well as many of the surgeons over the world. Actually, provide great ideas. So I started to search for this sort of possibility to reconstruct both dorsal and volar. By luck, I read this paper actually 2 decades ago. It is not a very eye-catching paper. It is a paper from the University of Pennsylvania of Moham's group, actually talking about using a very simple idea, using a tendon loop around the scaphoid and the lunate in 4 cadaver, actually can produce very good biomechanical outcome, almost restore the scapholunate gap to normal and improve the scaphoid and the lunate contact with radius. That has been also substantiated by another study about 9 years late after by the Scandinavian group, actually performing 2 tendon grafts along this tunnel, and actually in 90 cadaver actually demonstrate no difference in mechanical property from the normal wrist. So these are very exciting news for me, because now you can say a simple looping around the bone can produce a good result. But when looking at the clinical history, there's not been any kind of clinical series before. Retrospectively, I heard that in the Mayo Clinic, they have done similar idea in the 70s, but end up into disaster, because by making a hole over the scaphoid, proximal scaphoid, it actually invite for trouble, like avascular necrosis, like fracture, and so on. But in the era of arthroscopy now, I think we may consider again, because with the arthroscopy, we may avoid opening the joint capsule. With the arthroscopy, you can actually visualize everything inside the joint and make a decision and make the assessment. So I decided to think about in this so-called box reconstruction concept, both simultaneously dorsal and volar reconstruction with a tendon graft and the looping around the proximal scaphoid and the lunate. Advantage, we can preserve the capsule, we can just open the skin, retract the tendon, and we can keep the capsule completely intact. With the help of the image intensifier, we can actually locate and design the bone tunnel precisely, and most importantly, with the arthroscopy, we can evaluate the wrist joint, we can evaluate the stability, and then, particularly after the reconstruction, we can evaluate whether the reconstruction is good enough and strong enough to provide the stability. So this is actually my first case back to almost 20 years ago. 2002 is a very severe scapular dissociation. It was a big challenge for me. I think about this method because I know that ordinary method may not work for this patient. And so I tried 2 times in the cadaver and make sure that it worked out. So this is a complete drive-through side, no doubt. So I passed 2 tendon grafts, pull the tendon together, and immediately you can see that it gives you a very exciting feeling because once you pull the tendon, the joint comes back easily. And at that time, I still put a pin across, which actually turned out to be some mistake. And actually it was quite enjoy. And this is about 1 year afterwards, still maintaining good alignment and so on. Quite happy outcome. What about the test of time? This is almost 20 years down the road of this first case in my career. You see that radiologically there's some bound off about this gap. It's not as good as initially, but it's also not as poor as the initial. But actually, radiologically, they still maintain the stability. But most importantly, you can see clinically, he was absolutely enjoying the result of the surgery. No pain, excellent range of motion, and he was very satisfying. So even 20 years of time, this surgery could still test the challenge of times. So I think the key to success is before you can put the patient into this successful surgery, ensure that the instability is reducible. I like to use it in the intraoperative using the intraop X-ray to see that by radial and hour duration, whether the scapulonate gap can be reduced and also improve the scapula alignment. And sometimes in some easy case, you can see by simple using the thumb to push the scaphoid from a subluxed position, it can reduce the joint and also the DC deformity. So these are excellent cases for you to consider soft tissue reconstruction. And sometimes for those more less reducible case, I often found that arthroscopy capsular release can help to improve the reduction. So like in this is a demonstration in cadaver. Typically, I will using this incision to locate the scaphoid tunnel, and then the split extensor reticulum, split the ETC tendon, and then you can locate the lunate tunnel. So that is usually quite simple. So on the volar side, I make a transverse incision, protect the median nerve cutaneous branch, and then locate the volar tunnel position. So this is under X-ray guideline. We create a tunnel at the proximal scaphoid, and also at the center of the lunate. We make the pin convergence so that we can actually help to reduce the DC deformity. Create the bone tunnel 2.5 millimeter past the palmaris longus tendon graft from dorsal to volar, and then from volar to dorsal back to the dorsal side. Put it back to the traction tower to demonstrate by pulling the tendon, the scapular joint can completely reduce, and then put the wrist down, maximize the tension, suture with the non-absorbable suture. So that is actually relatively simple and straightforward. Like this patient having a spot injury, failed arthroscopic reduction of the scapular injury at 4 weeks' time, and came back to my practice about 11 weeks. So this becomes difficult to treat with the acute method, so we decided to do this reconstruction method. So you can see that with this, we will actually immobilize the wrist for about 8 weeks, and then we remove, allow active mobilization. So you see this patient just by about at 8 weeks times, the patient's already just removed the space. The patient's already enjoying quite nice range of motion and also good results. So this is 8 months after the surgery. The result can be sustained. So how about with times 3 years down the road? So the radiologically, they still maintain very nice radial alignment, so indicating that the soft tissue actually reconstruction is quite robust, and also the clinical outcome is very satisfying. So we have more cases like another patient with the mechanics, 36 years of age, actually having an injury at work. Somebody did a scapular dissociation, open repair with the suture anchor, but the pain recurs simply after 5 months' time. You can see the diastasis, dorsal translation, and DC deformity. So these are the typical patient, very tender scapular joints, positive grinding tests, and also with the positive Watson sign, quite significant Watson sign clung over the wrist, which can be felt by the patients. So we performed this surgery in 2015 using the same technique. Again, you can see by pulling the tendons, you can see the reduction of the scapular joint quite readily. And so that is the beauty of this technique, relatively simple and easy to locate those bony landmark. And we, in this case, we actually put the pin across the scaphocapital joint in order to protect the repair, which we may or may not do depending on the chronicity of the injury. So we removed the KY at 8 weeks time, like in the last patient. We start mobilization at 8 weeks time. You can see we have an opportunity to review the X-ray. You can see the joint is very stable. By the time we just removed the KY, so we mobilized the patient according to our regime. So this is 4 year, 1 month down the road. Again, you can see range of motion clinical outcome is quite excellent. When you do arthroscopically surgery, you can actually preserve the soft tissue. Is really nice. MRI. We have a chance to do a rescope in this patient about 2.5 years because of minor pain. Actually, we can see that in the scapholunate junction was filled up by some fibrous tissue. There's no gap, no stepping. So I think the scapholunate reconstruction is pretty good. This is almost after 5 years. You can see alignment still maintained as compared to pre-op. There's a huge improvement in the radiological alignment. Another patient, wide diastasis of scapholunate joints, dorsal scapholunate subluxation. Clinically, very significant Watson side with clunk, repeat constant clunk on doing this Watson test and patient feeling pain at the back of the wrist. We performed scapholunate reconstruction in 2012. Same technique. This is 9 years, 7 months down the road. A very nice radiological outcome, no change over the time, and clinically almost perfect function without any pain. Last case, also similarly severe diastasis, severe subluxation, reconstruction 2010 by Dr. Wayne Lim Chair. This is 7 years down the road. You can see clinical outcome excellent, and also radiological, 10 years time, no change. So this is a very robust reconstruction that we are quite happy. Nowadays, we have much more reconstruction method, particularly this very remarkable method by my good friend Fernando Corella, excellent reconstruction. But I always think that is a bit complicated. It's not easy, and sometimes it's risky. So you need to be really master your fluoroscopy technique well. I also found Dr. Sangeet, my friend, has an idea of putting the internal brace with the screw. I think this is similar reconstruction, but with the addition of this internal brace concept. I think there will be some way to go with the improvement of my technique in the future, that maybe the internal bracing may improve the stability and also can enhance the rehabilitation. So in summary, I think this arthroscopic assist box reconstruction is very good for the stage 3 and stage 4 reconstruction where the DC deformity is reducible. But sometimes when this is not reducible, with the arthroscopy, you can actually make the joint more reducible, and that is rendered to be accessible with this surgical technique, which I still enjoy very much, and the long-term outcome is still quite good. So once again, thank you for the opportunity for me to share with all of you.